Hello, everyone. Happy Thursday. Welcome back to VMR. I haven't had a chance to say that for Thursday in a couple of weeks, which feels really, really nice. What also feels really nice is the chance to discuss a case with someone who I've actually worked with clinically. I'm thrilled to share this lukewarm seat with Harry, who I've known since he was an intern, now an R2 um, at UCSF. And Harry's been part of CP Solvers for almost a year and a half now, initially with the emails team, and then increasingly so with our VMR space. And we've gotten to take care of patients in real life together, Harry, and I'm excited to be able to do that virtually today. Before we intro the case presenter, I just want to pass the mic to you to see how you're feeling because I know this is probably the first time you've done this.
Yeah, it's the first time, so I'm nervous. I'm excited. It should be fun, hopefully. Looking forward to learning a lot and talking about medicine as always. So hopefully it's going to be a good time. But hopefully Mohammed has something simple for us.
I doubt that somehow. Somehow I doubt that. Hey Harry, tell folks a little bit about you outside of medicine since we'll spend this hour diving in Muhammad's case.
Yeah. Outside of medicine, I live in San Francisco. I enjoy running and reading. The second one I haven't been doing as much as I would like during residency, but I think that's pretty typical. Spending time with my wife and her family, who's a Bay Area native, um, and trying to juggle all that while doing residency. So it's hard, but it's fun, and I'm in a great place, and I'm loving residency, getting to learn about medicine, but also trying to find time to do all those things I enjoy outside of it. So, but
100%. Yeah.
yeah,
Reading and running are my two favorite things. I realize that both of those start with an R, so I must confess that hanging out with Reza is another third R that I love doing. I will say that Harry got married very recently, and I still remember when we were working together. I had the privilege of knowing that he was about to propose to his future wife when only a few number of people um, were or had privy to that secret. And yeah, I think there's one other person here with a secret, and that's Muhammad, and the secret answer to his secret case. Muhammad, tell us a little bit about yourself, please.
My name is Mohammed. I just finished internal medicine residency at Ain Shams University here in Cairo, Egypt. Currently applying for a nephrology fellowship here in Egypt also.
Wonderful.
I have a pretty interesting case. Diagnosis is pretty simple, but it's a very uncommon presentation.
Amazing, amazing. Well, thank you so much for that, Mohammed. We're thrilled to be able to have you here. Tell us a little bit about your background. Are you originally from Egypt? Have you been living there your whole life? What's that story?
I was born here in Egypt. I traveled and I stayed in United Arab Emirates for some time. But I returned to Egypt for medical school.
I see. Wonderful. How did
Yeah.
you find nephrology as your passion?
Nephrology is very interesting because I like numbers and because I've seen like nephrologists being very smart in our hospital and very like one of our nephrology professors used to say that medicine is part of nephrology, not otherwise.
Yeah, I love it. I love nephrology is the bigger picture, huh?
Yeah.
Small subset, yeah. Well, hey, listen, I love numbers too, and I hope we have a twist some nephrology in your case today. It would be really cool to learn from you and from your interests. But thank you for joining us. We're excited to hear your case and are ready to jump in.
Okay, so our story starts today with a 61-year-old female who has been complaining of generalized skin rash for 2 weeks. So her history started 1 month ago when she started having headaches, bifrontal headaches, and she was discovered to have high blood pressure. Her blood pressure at that time was 160 over 90, and she was prescribed some ACE inhibitors. However, she was not fully investigated as the cause of hypertension. They thought it was essential hypertension. She also had some cough and expectoration and watched sputum, where she was treated as community-acquired pneumonia with oral azithromycin, and she symptoms improved. 2 weeks ago, patient started having the generalized itchy rash, starting from the lower limb, but quickly progressing to the trunk, back, and upper limbs. She also described some lower limb edema of progressive course. The dyspnea increased, and now she has orthopnea but no paroxysmal nocturnal dyspnea. She reports no fever, chills, weight loss, or night sweats, no coughs, no oral or skin ulcers. However, she also complained of reddish discoloration of the urine, but no other sources of bleeding. Her past history is she has knee osteoarthritis on acetaminophen as needed, and she has been menopause for 20 years. And that's no significant social history or surgical history or high-risk behaviors. So that's the end of the first allegory.
Ahmed, you're presenting with such clarity and it's so easy to follow your presentation. Thank you so much. What I love so much is the sequence of events you've outlined for us is so clear, and that's so key to analyzing this case. Um, and I also love that you managed to get the word urine out in your first aliquot. Your passion is there. I love it. Harry, I know your mind. I imagine your mind's probably tempted to start to weave this together, but I think folks have a lot to learn from you about where you're beginning. So you got this whole slew of data, and I'm curious, before you share with us how you're putting it together, I think it's helpful for people to hear how somebody who is seasoned into medicine, 2 years into seeing patients, where you're choosing to start your thread and why. What do you think?
Yeah, I think some of that depends on where I'm seeing the patient. So if this is someone who's walking into my clinic talking
Yeah.
just fine, I think my tempo is a little bit slower. But if I'm seeing this person in the emergency department, something is triggering them to come in that's more emergent. So depending on how they look, I might start with the most acute thing, which the vitals will help, but also seeing what the patient in the rash looks like. If I see the rash and it's really scary looking, just to be simple, it's sloughing off, there's a lot of lesions that I'm really worried about this patient having some sort of systemic illness. I'd start with the rash before I work backwards. But I think in real life, I would really depend on what the patient actually looks like and what I think the rash could be
Yeah.
and where I'm seeing the patient. I think right now, when I'm thinking about this rash, I think the temptation is to start with something that started about 2 weeks ago. It seems like medication is always on the top of the differential in this situation, especially with the generalized rash. I'd be curious to see where exactly the rash is at this time, if especially if it involves the palms and soles, because I think that differential is a little bit different in terms of infectious etiologies. I think that the interesting thing, and maybe I'm anchoring and being biased by Mohammed's interest in nephrology, is that it's not just a rash, but it's also some swelling. So they have bilateral lower extremity edema, some orthopnea and dyspnea, and then also having some red color urine if there's something systemic that can tie us together. And if there's a glomerulonephritis, patients losing protein, they're having some blood in their urine as well. So I'd be curious to see if we can get some more data later on. I think the interesting thing is that it's just bilateral lower extremity edema. It doesn't seem to be upper extremity edema, but our exam will help us figure out because when I think of bilateral lower extremity edema, orthopnea, dyspnea, heart failure comes to mind. But with things like nephrotic syndrome, cirrhosis, you kind of see some more either abdominal swelling or upper extremity swelling, so more generalized anastochia, but not usually just lower extremity edema. So I'll be curious to see what the data shows and what our good thorough exam shows. But I think if I'm seeing the patient in the emergency department, I'm making sure that they're stable and safe. I'm thinking about the etiology of the rash. Is it something systemic that's unifying all these symptoms, or if it's like infectious or drug-related rash?
I know, I absolutely love that. I think your analysis is superb, and I'm in a very similar place. I think that if I were to see this patient in any context, I think that what you're teaching us is twofold: is how the patient triages themselves gets you to think differently, and also finding visual or examinable correlates for what you're seeing changes the calculus. So if you see that this patient's dyspnea is, you're probably going to think about the dyspnea. if you see the patient, this patient's rash is a necrotic purpuric rash, you're probably going to think about the rash. So what happens immediately and what grabs our attention is seeing objective correlates of what the patient's saying. I think that without that, this is the beauty of clinical reasoning, is you're forced to get as much juice out of the data that you currently have, and you're ready to modify it as soon as you get more data. I think that we always tend to start with the patient's chief concern, but as is true of anything, that may not be our chief concern because we know more about medicine than the patient does, but the patient knows more about their body. And so it's a dance between our knowledge and their knowledge. And so I think in this circumstance, I'm going back to sort of a very systematic, rigorous approach to rash, which is what the patient's chief concern is. And with a rash, you want to know 4 dimensions of that rash. The 3 dimensions are studying the rash itself. How extensive is it across the body? How deep is it in the skin? And how much does it evolve over time? So here, the answer to those questions, this is a almost whole body rash, sparing the face. We'll see how deep it is to see if it is nodular, purpuric, or how superficial it is if it has scale. And the time course is 2 weeks. So we can definitely say it's wide. We can definitely say it's evolving pretty quickly. And then the 4th dimension is association with systemic symptoms. And here the answer to that is absolutely yes. So what do we do if we have a rash that is extensive and is associated with systemic symptoms? My honest opinion is that what happens is similar to what happens in this analogous situation. You have a patient who comes in and they tell you they have a headache. You then do an exam and find that they have focal neurological deficits. How are you analyzing this case? Are you saying that this is a patient with a headache who has focal neurological deficits? Probably not. What you're probably saying is that this patient has focal neurological deficits, and the headache helps you localize those neurological deficits to the brain. And I think here, the fact that the rash is part of a systemic disease simply means that the rash is the tip of the iceberg. And a dermatologist is probably set up to study the rash and understand the systemic disease second. What you and I are set up to do is to better understand the systemic fingerprint of the disease, because to us, we're likely not going to be able to make as much progress on the nature of this rash as we would on the nature of the systemic disease. And so I heard that in your analysis. You really said, okay, rash noted, but I really got to understand what the systemic disease is here. And I think understanding the combination of blood pressure elevations, orthopnea, dyspnea, edema is going to be key. And I have nothing to add to that reflection, but to make the emphasis that when hypertension and edema go together, when they're abrupt and simultaneous, it's often a clue that the kidneys are involved. Of course, you can have hypertension cause long-standing hypertension cause heart failure, but this person's hypertension appears to be new. Connecting it to LV dysfunction when it's so acute is unusual. Hypertension is almost incompatible with cirrhosis. So I agree with you. I think it's easy to frame this now as a potential kidney plus rash issue, but I think being open to other causes is really important. All right, Mohammed, tell us more, please.
So our examination shows it's very helpful. Blood pressure is 160 over 90. Heart rate is 94. Respiratory rate was 24. Temperature was 37 degrees Celsius, and saturation was 92% on room air. Patient was orthopnic. Cardiovascular examination was normal. Normal S1 and S2, no murmurs, rubs, or gallops. Here, pulmonary examination shows decreased intensity of breath sounds bilaterally with basal crackles. No abdominal examination, no non-tender, no ascites, no palpable organomegaly. Her extremity shows low bilateral symmetrical pitting, lower limb edema above the level of the knee. And her skin shows, her skin examination, macular, violaceous, palpable, non-blanchable rash. I have some photos if you want to see.
You should be ready to be able to share them, Mohammed, whenever you're ready.
Yeah, sure. So this is the rash that was present on the patient. Lower limbs, upper limbs, skin, trunk, and back.
Pictures do tell 1,000 words. Harry, what are you thinking of this rash?
Yeah, I think if I heard correctly, it sounds like it's a non-blanching rash. It looks like um, either coalescing petechiae or maybe some purpura. Uh, and, and I may have missed if it's palpable or not, but I think there's concern that this is inflammatory etiology for me because if it's non-blanching, palpable purpura, and then if it's so systemic as well. So I think uh, it it sort of guides my thinking, but I think I'm still overall concerned for some sort of systemic process like a vasculitis versus leading to a glomerulonephritis, leading to edema, et cetera, et cetera. But I think some of the laboratory data will help guide that. But I think uh, I'm not too surprised, I guess, by this appearance. But I am. It does make me excited.
Yeah, no, I think that like if you saw this in real life, I think you'd probably be like, whoa, okay, this is so unusual and really helps reinforce an unusual chain of thinking. Like when somebody comes in with edema and hypertension and a headache, I think you're probably open to something very common, just a series of probably unrelated things. The patient has a migraine headache and has primary asymptomatic hypertension, but the presence of these things simultaneously really allows you to say, hey, there's something unusual going on here. So I think so. So what I hear you saying is like you're seeing you look at this and you know that there's bleeding into the skin, basically. And the real question is the patient bleeding into the skin because of a blood problem, like low platelets or high INR? Or is the patient bleeding into a skin because of a blood vessel problem like vasculitis? And blood testing, as you have been patiently waiting for, will help you understand if the patient has thrombocytopenia or coagulopathy. But what is really helpful is to be able to see if you can feel this rash, because if you can feel this rash being palpable, that helps you infer that the blood vessel wall is thickened, inflamed, and leaky. And you can literally feel the collective thickness of all those blood vessel walls synchronized together. So if you're really being strategic about this, the patient's bleeding, and is it because their blood is thin or is it because their vessels are thick? And if you can feel those vessels, you can make progress towards that way. And I think Muhammad said it was, in fact, palpable. So the odds of you being able to find a coagulopathy or a deep thrombocytopenia is low here. So I'm curious if maybe we can go back to Ethan's screen and analyze the rest of the data. And yeah, I'm really curious because you got some signal on exam, Harry. What are you doing with that?
Yeah, so I think we talked about the rash being palpable. I can see that now. I think the other signal is that the stat is kind of interesting. Maybe not surprising given the patient's reporting dyspnea, but now a little bit of hypoxia too, very mild, but as well as some decreased intensity of breath sounds. It seems like bilateral crackles, so something in the alveolar space that's also affected too. So, now we have cardiopulmonary, we have possibly renal. We'll see with the data, as well as rash. So, I think so I think the data the labs would be really helpful. So a chest X-ray would be helpful. I think just I don't want to be too premature, but I think unifying things are some vasculitis, GBM disease can also have some pulmonary involvement, um, and as well as some of the ankylosing. So I think that'll be the most helpful still. I'm a data
Harry,
person.
Harry, you're taking this much further than anyone is able to. So I'll meet you there. Let's ramp it up. Okay. So this patient has lung involvement, right? You can hear it and you can see it on the pulse ox. So you're teaching us that the lung involvement may not actually be primary lung involvement. It may be heart involvement. And that's really the issue is not in the lungs. It's a consequence of something in the heart. That's heart failure causing pulmonary edema, right? And then you're teaching us that actually the heart involvement may not be actually heart involvement. It may be because the heart is stressed by kidney failure. So you're going all the way from the lungs to the kidneys. And I think that really important to recognize that while most pulmonary diseases are intrinsic, there's pus in the lungs, there's aspiration in the lungs. The sequence of pulmonary edema pushes us outside of the lungs into the heart and sometimes into the kidneys. The other dominant organ that tends to force disease into the lungs is the neurostatus when patients aspirate or have diaphragmatic weakness. So you all can strengthen those neurons that you have of not zeroing in on the lungs, but extending your gaze to the heart and sometimes the kidneys and extending your gaze to the neurostatus. And here we don't have any reason to extend our gaze to the neurostatus, except maybe a mild frontal headache. So we're probably thinking, are the heart and the kidneys on the hook? But at the same time, it's probably really important to build hypotheses about an actual lung issue that is in the lung. So are there any, to stretch our thinking and practice our clinical reasoning, are there any hypotheses that you think are reasonable that are intrinsic lung diseases in this patient? Say her heart and her kidney are not fully responsible for her pulmonary findings. Can you think of any possibilities in that scenario?
I think I think based off her specifically,
Yeah,
uh, the so it seems like the way I would approach it is just like any patient with hypoxia, separating it into hypoxia and dyspnea. So dyspnea pyramid, lungs. Think about the lungs specifically.
yeah,
If you throw on oxygen, it doesn't. If it gets better really quickly, then I'm worried about things like ventilation issues like COPD, et cetera. It doesn't seem like she has risk factors for that, given her health-related behaviors. And then if it doesn't quickly get better, then I'm concerned about an AA gradient situation, which we kind of alluded to some of them.
yeah.
So whether it's fluid, blood plus
Nice.
in the lungs, pneumonia, for example, if there's like a parenchymal disease. So for her specifically, um, a unifying thing could be some sort of rheumatologic disease or autoimmune disease, I should say, leading to some sort of interstitial process. Um, I think it's hard to say right now exactly what that would be, but a few things like she doesn't have joint pain, could be RA, scleroderma is one that could be involving, could lead to some of these manifestations, um, leading to ILD as well. I think primary lung disease, a whole bunch of things
Yeah.
depending on where along the dyspnea pyramid or where along the hypoxia thought chain you are.
Yeah, I agree with you. I think that you're absolutely right. I think the theme of rheumatological diseases is the key here. And then when you apply the filter of acuity, what you're supposed to think about right away, I'd really entertain the possibility that she might have diffuse alveolar hemorrhage and might really collapse in front of us. And the worst thing you want to do to that patient is to diurese them when they're bleeding into their lungs. So for me, where I'm at, I think that there's a really likely an alveolar filling process here by evidence of the crackles and the hypoxemia. And the questions that I'm asking are, is this water from pulmonary edema, cardiogenic or nephrogenic? Or is this blood? We see that she's bleeding into her skin. She might be bleeding into her kidneys, as evidenced by the blood tinge urine. And is she bleeding into her lungs? And having that hypothesis early on allows you to study her imaging with more clarity to try to distinguish DAH from pulmonary edema very early on. And so, and then also, if you think of that early, you might think of pulsing the patient very, very quickly. So that's a thread we'll have to explore. You mentioned how you're thinking about the vasculitides, which I think are very wise based on the rash, and how you're entertaining the possibility of glomerulonephritis based on the hypertension. And I think one interesting thought exercise for you to do for the next aliquot is to ask yourself, how does the world of vasculitis interact with the world of glomerulonephritis? Because we often simplify them and we kind of merge them into one bucket because there's a lot of overlap, but it's not perfect. And I'll give you an example. A hypothesis that you brought up, which is a very reasonable one for pulmonary renal syndrome, anti-GBM disease, will not cause palpable purpura. That's because glomerular basement membrane is so specific to the lungs and the kidney that it does not have any extra pulmonary renal manifestations. It's beautiful in that way. It simply knocks out the kidneys, knocks out the lungs, but should not leave you with a vasculitic rash. So it goes to show you that analyzing this space, vasculitis versus glomerulonephritis, and seeing what the overlap is, but also what's unique about each, can help you make quick progress in a case like this. But I think it's too soon to assume the patient has glomerulonephritis. We should probably see if that hypothesis bear fruit. But that's an exercise that we can do together. If she does have GN based on the UA and she has vasculitis, how can we get juice out of the fact that she has both, not just one or the other? All right, Mohammed, tell us more, please.
Yeah. Uh, Someone in the chat asked about, said urine analysis is next, and I think he's going to be a very good nephrologist because we think that urine analysis is part of the physical examination, not part of the labs.
Remember, Mohammed, there's the UA, and then there's all the other small blood tests that don't
Yeah.
matter.
So let's start with urine studies. We have bus cells 15 to 20, RBCs 60 to 65, granular costs, albumin 2 plus, and we have a 24 urinary protein of 3,000 milligrams per day. CBC, we have a white count of 4.9, hemoglobin of 7.1, normocytic, normochromic, and platelets of 124. Basic chemistries, we have a BUN of 92, creatinine of 2.5, sodium 137, potassium 4.8, bicarbonate 16, calcium 8.6, albumin 3.1, phosphorus 4.1, magnesium 2, uric acid was 12, and normal AST, ALT, and total bilirubin.
I think I know Ethan's catching up because of the fancy UA results. But Ethan, I can tell you that the BUN is 92. I'll just tell you the important stuff. And then the creatinine is 2-ish. I'm sure it's not exactly
2.5.
2.5. Awesome. Thank you so much. And the rest was okay. So I think you got it all. All right, Harry, where are you at?
Yeah, the UA. I'm not used to getting the UA first, so I'm still grappling. But I think it's concerning and it's interesting at the same time. Unfortunately for the patients, I think you got whites, you got a lot of reds, and you have some albumin, and then a lot of protein. Um, Making me concerned kind of again for the GN, a glomerular process of GN specifically, especially because there's a lot of albumin. I think it'd be nice to quantify the albumin, see if it's mostly albumin, but I think it raises my concern for glomerular process still. Other causes of intrinsic AKI aren't necessarily out of the picture, but I think it raises my suspicion for glomerular process highest. Don't know the baseline creatinine, but I'm going to assume this is higher compared to the baseline, as well as the uric acid makes me again concerned that there's some sort of acute kidney injury going on here. I think reassuringly, no white count to speak of, but the hemoglobin is also something concerning, assuming that this person was, a month ago, previously healthy and had a normal hemoglobin, that the hemoglobin is a significant drop to 7.1, as well as the mild thrombocytopenia. I think given the lung sounds, text that's really helpful, but I think at some point, if we are worried that this person is bleeding into the pulmonary space, we might need some cross-sectional imaging going ahead. But I think if I was seeing this person at night, I would probably consent for a blood transfusion because I'm worried that this is where it's heading, just as like a stabilizing concern. But I think worried about the anemia, mild thrombocytopenia, worried that she's bleeding somewhere, possibly into the lung space. Usually if she's not hemoptysizing, I would be kind of surprised that her hemoglobin would be so low because the alveolar space isn't that large. if it is DAH, but never say never. Um, but I think, yeah, I'm worried about her bleeding, and I'm worried about glomerular process right now.
I love it. I'm right there with you with that analysis, and I think we should tug on both those threads in more detail. To kind of show you a neat trick of how you can be very confident this person has glomerulonephritis, we can go through a thought exercise together. Sort of just like rapid fire from your residency experience. Um, if we just focus on the hematuria, can you share with us like what causes you've seen as common conditions that result in just hematuria? What do you think? What have you seen in residency so far?
The hematuria without
Yeah, just
hydration.
hematuria. Yeah, that's
Yeah,
all you know. Say your patient comes in and you know they have hematuria. What are the common things you've seen? And you don't have anything else about them. You just have the UA.
yeah. So I think the most common thing in the hospital is like a traumatic fall replacement, honestly.
Yes. Yeah, exactly. Yeah.
Yeah, so and yeah, that has a little bit more macroscopic hematuria, which she does endorse a little bit of.
Yeah.
But of course, a lot of microscopic hematuria can also
Yeah.
appear as macroscopic. So, trauma is a common one.
Mhm.
Um, for female patients who are menstruating, that is a common
Mhm.
one as well. I see a lot in clinic. Um, and then yeah, and then I think more kind of urological things. So
Yeah.
if there's for example, like a renal mass, a bladder mass,
Yep.
that could also be causing pure blood rather than both pyuria as well.
Superb. So watch this. What of those cause both hematuria and AKI? Nothing, right?
Nothing.
Nothing. The combination of hematuria and AKI is only three things that can do it. So, what can you think of that causes both hematuria and AKI?
Yeah, so a lot of the intrinsic processes, so glomerulonephritis, of course, interstitial nephritis, uh, and I'm probably blanking on one on the spot,
Yeah.
but
The other one is very common issue, which I'm sure you've seen, where somebody has
infection. Yeah,
obstruction. Exactly. So,
yeah,
yeah, exactly. So, the interesting thing about that is that when you have intrinsic renal diseases, the most likely intrinsic renal disease to cause hematuria is glomerulonephritis. Most patients with interstitial nephritis have pyuria, not so much hematuria. So if you think about the collecting system in the kidneys in three categories, there's the kidney itself, there's the ureter, and there's the bladder. There's one cause of hematuria plus AKI in each category. Bladder outlet obstruction from bleeding. Ureter, bilateral kidney stones simultaneously. And then in the actual kidney itself, glomerulonephritis. So here, she's not having overt macroscopic hematuria right now. She has only 60 RBCs, not over 180. So it's not bladder outlet obstruction. She has no symptoms of a kidney stone, right? So the fact that she has hematuria and AKI without evidence of bladder obstruction or kidney stone means that she has glomerulonephritis. It's almost impossible for her not to, simply because of the combination of hematuria and AKI without suspicion for bladder outlet obstruction and without suspicion for kidney stone. And so then you can just use that combo to really say, okay, is there anything else that suggests nephrotic syndrome? Glomerulonephritis, excuse me. And the answer is heck yeah. Her albumin is low, she's got proteinuria, and she's hypertensive. So I just emphasize that the combination of hematuria and AKI allows you to have an operating framework for GN that allows you to make progress. The hard part is to diagnose glomerulonephritis before it has resulted in kidney injury. That's when it becomes really tricky, but after it becomes much easier. And so hold that thought exercise in your mind of hematuria plus AKI. The DDX is three things, and you can eliminate two of those three things effortlessly when the patient is painless. Hematuria. And so, yeah, I think the other dimension that you're thinking about here is the anemia. And I love how you didn't just chalk it up to the anemia of kidney dysfunction and you're worried that this patient is actively bleeding. I think that's very wise. There are some nuances with DAH that are worth talking about. Only 1/3 of patients present with overt hemoptysis. So the question is, how do patients with DAH become anemic? And it's actually both bleeding, but the bleeding is often low grade, as evidenced by the fact that 2/3 of patients don't cough up their blood. So how do they get anemic? They actually get anemic through iron deficiency. So this is basically like the patient with that small bowel bleed that nobody can find. They bleed, they ooze. Because remember, diffuse alveolar hemorrhage is actually just capillary bleeding. So if you imagine, do capillaries really gush? No, they just ooze a little bit over time, usually months. So most patients with diffuse alveolar hemorrhage, the mechanism of their anemia isn't so much that they're losing hemoglobin, it's that they're losing iron. And so if this patient were accidentally on oral iron supplementation for another reason, she may not ever become anemic, even though she's having diffuse alveolar hemorrhage. So the name is so dramatic, diffuse alveolar hemorrhage, but it's probably better to be like diffuse alveolar trickling is a much more realistic name for what happens in most people, though some patients then do in fact hemorrhage. Um, but I agree with you. I think we're on that train. And I think I'm trying to think if we should do the vasculitis glomerulonephritis exercise now, but I think we've talked a lot. So maybe we can get a little bit more information and see what we can narrow it down to. All right, Mohammed, tell us more, please.
Uh, Very excellent points. If I may add, now the reason why you love urine analysis so much, there are four signs of glomerular injury. Proteinuria, which the degree of proteinuria is almost nephrotic. So this points to glomerular disease rather than tubular disease. Hematuria, loss of GFR, and glomerulitis, which is evidenced by the post-proteins and high RBC in the urine. So this patient definitely has a glomerular injury. Uh, Moving on to the imaging studies. So we have an CT chest showing picture of pulmonary edema, mostly central consolidation rather than peripheral ones. Ultrasound shows normal size kidneys, no back pressure. Her liver is 18 centimeters and her spleen is 18.5 centimeters. So that's splenomegaly. Her echo was ejection fraction was 33% and some rim of pericardial effusion. So more labs. We have a virology was negative. We have an ESR of 89. ANA was negative. DNA was negative. C3 was consumed, 74. C4 was also low, 2. ANCA was negative. We also did a serum protein electrophoresis, which shows mild hypoalbuminemia and moderate hypogammaglobulinemia with no evidence of imbalance. And that's the end of this alloc.
Very helpful, Mohammed. Thank you so much. Yeah, Harry, what are you struck by? Where are you going with this, you think?
Yeah, I think kind of going the order that Muhammad presented it. I think the CT chest, not super surprising. I think our exam kind of correlated with that. Um, the spleen is a little bit enlarged, which could explain some of the, some of the findings, but doesn't completely explain a lot of the CBC abnormalities, of course. It does make me worried that there's some sort of uh, uh, yeah, I'll get back to that. I think the echoes we're sharing kind of I think cardiac pulmonary edema is kind of always lower on our differential, but it's good to rule that out, especially in someone who may have had been hypertensive for a while. But again, no big surprises there. Finally, getting to some of the rheumatologic stuff. So ANA negative, doesn't it's not super surprising. I guess it is reassuring. There are some rheumatologic processes, especially in this demographic, um, that could present. Lupus can feel like anything. It'd be hard to say that she has lupus at this point with the negative ANA. Getting to the complements, it's the fact that they're low is actually pretty helpful. It's an immune complex mediated GN. Given that she's had recent, seems like some sort of possible illness with a cough and skin infection previously, I think post-infectious is possibly on a picture with the hypocomplementemia and all of these things going on. And then cryoglobulinemia, so I'd be interested to get like a Hep C as well. And then I think the ANCAs being negative are kind of surprising. I think the MPA, GPA kind of were higher on my differential, but sometimes sometimes I'm like hey, if a test doesn't show what I think, is the test wrong? Um, but I think I think that kind of brings the post-immune vasculitis is lowered on the differential. So I think post-infectious GN from whatever symptoms that she was having a month ago is possible. Um, Lupus is kind of lower down at the negative ANA, but of course you have seronegative, and then I think getting Hep C for cryoglobulinemia. Um, there are the mycoplasma could also present with cryoglobulinemia, and she had community-acquired pneumonia, so it's possible it's either cryoglobulinemia or post-infectious from that. Yeah, that's kind of where I'm at right now.
Excellent, absolutely excellent. I think that you're making a really a powerful point about the role of complements in your analysis. And I think if you step back and analyze the big picture here, most glomerulonephritis is autoimmune or rheumatologic. If you could only call one consultant for glomerulonephritis outside the kidney doctors to help you manage it, it's really the rheumatologist. And so the question is, when is that no longer true? If you sort glomerulonephritis by complements, normocomplementemic glomerulonephritis has to be autoimmune. That's where ANCA fits in. That's where IgA fits in. And that's where anti-GBM disease fits in. Normal complementemic, all autoimmune. What happens when you have hypocomplementemic GN, which basically makes ANCA, IgA, and anti-GBM dominant conditions in this space, much less likely? You're left with only one reasonable autoimmune condition, and that's lupus. There are other ones too, but you see that hypocomplementemic glomerulonephritis rapidly changes the calculus and dramatically reduces the probability of rheumatology consultation if the patient is ANA negative. See that? So if you say complements low ANA negative, your odds are you're not going to be calling a rheumatologist. Odds are. And that is tremendous change of the odds of compared to glomerulonephritis without further data. And that's where we are here. ANA negative hypocomplementemic GN is a very intriguing space and allows you to really shed the spotlight on non-rheumatological conditions, infections, which you talked a lot about. See how much you spent time talking about infections that she had, which you probably wouldn't otherwise. And so there's a range of infections that we think about. There's post-infectious complications like post-infectious streptococcal glomerulonephritis. There's active acute infections, which are really important to think about, and endocarditis being the most important one, most notorious one. And then there's chronic infections, like a Hep C and cryoglobulinemia, as you said. In a patient with hepatosplenomegaly, which could be the consequence of hepatitis C, of course, you also have to start to think about malignant causes. And that's where lymphoma and Castleman's disease can cause a variety of mechanisms for glomerulonephritis as well. So what's the progress we've made here? The progress we made is actually to say, hey, you know what? The base rate for glomerulonephritis probably doesn't apply. This person doesn't have lupus, and this person's hypocomplementemic. So I think the next key tests, honestly, are to get blood cultures to make sure that you're not sitting on endocarditis, is to get an anti-streptolysin and DNase to make sure that this is not post-strep. But in our heart of hearts, as you said, what are the most likely causes for glomerulonephritis and deep purpura, all the way to the chest? The most common causes of deep purpura are ANCA, gone, IgA, much less likely with low complements, endocarditis, very possible, but most importantly, cryoglobulinemic injury. And the sheer almost absence of C4 here has me leading our diagnostic arrow with cryo, as you alluded to. And so how can we test for cryo? The actual test for cryoglobulins is complicated because it's hard to perform accurately. So a rheumatoid factor can be a really helpful proxy for the presence of cryoglobulinemia, as is looking for a reasonable cause like Hep C or a lymphoma. Any questions about that, Harry, about the nuance of complements and how it helps?
No, yeah, that makes a lot of sense. That's kind of how now I'm thinking back about it, that's kind of how I thought about it, but I've never
Yeah.
articulated that, but that
Yeah.
makes a lot of sense.
No, I thought your thinking was on track, and all I did was just sort of add emphasis to how much this helps, but I think you said everything. All right, Mohammed, tell us more. I hope we're on the right track.
Yeah, ask and you shall receive. So cryoglobulins were positive. Rheumatoid factor was positive also. However, like we said, viral markers were negative. Hepatitis C and HIV and hepatitis B were negative. So how does this point the differential?
Oh, yeah, that's right. I forgot about the viral markers. All right, Harry. So we got cryos, we got a low C4, we got a positive RF, but our Hep C is negative. What do you think?
Yeah, so I think doesn't absolve other infections, of course, or even post-infectious. Cryoglobins are just and rheumatoid factor can be made in any inflammatory process, a really hyperinflammatory process. Uh, Given the age, the anemia, which she has other reasons possibly to have, the calcium wasn't super high. I think if I do my math right, it's still not that high, even if you correct for the albumin, whatever that's worth. But I think like sending for looking for hemopathies is possible, like myeloma. But I think lymphoma is also possible too. Um, so flow might be helpful if we're worried about that. It doesn't seem like her CT chest had any lymphadenopathy, but the fact that she had splenomegaly on the ultrasound is possible, makes liquid tumor possible as well. I don't think it necessarily rules out other chronic infections like chronic endocarditis that we haven't caught yet. Um, and I still think mycoplasma somewhere in the back of my mind can also cause issues with cryoglobulinemia, but I don't think now it's been a few weeks out, I'm realizing, so it's less likely. But I think flow cytometry would be helpful. Cross-sectional imaging of the abdomen might be helpful to make sure we're not missing some giant lymph nodes in the abdomen as well. And then HIV, I see as negative actually. So I think still infectious, still oncologic as well.
Yeah, absolutely superb. I think you're rounding out the infectious category and you're reminding us that not all infection-related cryo is Hep C. It's the most famous. HIV can do it, hepatitis B can do it. And actually, the list of infections that can cause cryo is long, really, really long, and many other things. So you kind of have to do a targeted assessment based on epidemiology in Egypt. But I agree with you. I think we have to entertain the other categories of autoimmune causes and malignancies. And you hit very robustly on the malignancies. It's lymphoma and Castleman's over and over and over again, and studying those and working those up is really important. I'm curious if you happen to know any autoimmune conditions that can cause cryoglobulinemia. Has that come across your radar at some point?
I feel like it has, but I'm blanking right
Yeah, well, that's why we do this. We reinforce those neurons. The biggest one is Sjogren's disease.
now. Mm-hmm.
And you can easily imagine how in a 61-year-old female, she's gotten used to dry eyes and dry mouth and put them aside. And so I think that the knowledge that that could happen, coupled with the knowledge that only 50 to 60% of patients with Sjogren's are ANA positive, does that push you to analyze that possibility in this case?
Yeah.
So what I would do is I'd ask her if she has dry eyes, dry mouth, and also examine closely her parotids, her salivary glands, and wonder if getting an SSA and SSB or even a lip biopsy is really important. Why is that hypothesis important? It's actually bridges the autoimmune and the malignancy sphere. So in patients who do have Sjogren's, who develop cryoglobulinic vasculitis from Sjogren's, their risk of lymphoma is 30-fold higher compared to patients who don't have cryoglobulinic vasculitis from Sjogren's. That interface of lymphoma, Sjogren's, and cryo is also actually an interface with hepatitis C and lymphoma. The risk of lymphoma in patients with Hep C, a specific kind called splenic marginal zone lymphoma, is very high too. So whenever you enter the world of cryoglobulinemia, you have to worry about the trigger, either infection, Hep C, or Sjogren's, and that also elevating the risk for a malignant transformation to lymphoma. So no matter what, even if we realize that this patient's Hep C is false negative and she has a high viral load, or we learn that she has Sjogren's, we have to not let the sun set on the possibility of a lymphoma that's related to those two conditions, Hep C and Sjogren's, or a primary lymphomatous process causing cryo independent of those two possibilities. So I think the simple things to do right now in order are an LDH, gives you a good sense of lymphoma possibility. Um, and then ask the patient about any mucosal dryness, and then maybe serologies for Sjogren's. That's probably where I'd be at. But I realize we're closing in on the hour, so I'll pass the mic to Mohammed to tell us more.
Yeah. So what we did was directly we jumped to a renal biopsy so that it will show all the hidden things of the kidney. So the renal biopsy showed some multiple hyaline thrombi. I'll read you the diagnosis so it's quicker. Immunohistochemistry showed a restriction for lambda chains. Electron microscopy showed microtubular structures in the electron dense deposits in subendothelial region. The diagnosis was cryoglobulinemia glomerulonephritis with evidence of lambda restriction. Now, when we saw the lambda restriction, we returned to the serum protein electrophoresis, which was normal. And we thought we needed more serum immune fixation and serum free light chains, which we then showed an IgM monoclonal band on the serum immune fixation, making this myeloma related disorder. So this patient was referred to hematology for myeloma treatment after taking a bone marrow. One of the differentials of uh, hypocomplementemic glomerulonephritis is myeloma. We always forget that myeloma does cause low complement levels in the kidney.
Very, very interesting, Mohammed. Can I ask, do you know the results of the bone marrow biopsy?
Yeah, it was multiple myeloma.
Wow. And do you know how many plasma, did she have a lot of plasma cells or was her burden on the lower side?
No, it was like 35%.
Wow. Fascinating. Fascinating. Harry, what are your thoughts?
It's interesting but unfortunate, of course, for the patient, as the case is sometimes. Uh, yeah, I think I appreciated Mohammed going through the renal biopsy. I feel like I never really think about what the actual pathology means. I just kind of look at the report and kind of ignore all the fancy words that I learned in med school. But I think it's fascinating. I think I didn't really have uh, uh, monoclonal gammopathies as I know it's intrinsic renal disease, but it's not always at the top of my differential, so it's a good reminder for myself. Um, and it kind of makes me wonder if this headache that she had been having, her blood pressure wasn't super high, but is this like a viscosity? Is it, looking back, is there some sort of hyperviscosity going on, given that it's a lot of IgM um, disease? If she has other manifestations from that, it's hard to say. But yeah, it's really interesting. What do you think?
Yeah, no, I really enjoyed this case. I think that the journey towards the discussion of the rash and the kidney, and then the journey towards glomerulonephritis and the kind of glomerulonephritis was awesome. And I'm really glad that we got to go there and then learn a really precious lesson about how myeloma can show up in this space. I have to say with you, like the showing up of myeloma in this way is very interesting and very intriguing. And it makes sense to me, and pushes me to update my own script, because if this is this is diagnosed bone marrow proven multiple myeloma, it's an IgM multiple myeloma, which is pretty rare. Most IgM related paraproteinemic disease is from Waldenstrom's, and not from multiple myeloma. But Waldenstrom's does not show up in this way, and so I've never seen IgM related multiple myeloma before. And it doesn't surprise me that it's a little bit different than our classic IgG multiple myeloma, because here it's disobeying two key rules for multiple myeloma. The first of which is that most patients with multiple myeloma have no splenomegaly whatsoever. And most patients with multiple myeloma have bone lesions, lytic bone lesions. And maybe Mohammed didn't tell us just for the simplicity of the case. But it just goes to show you that when we're really discussing multiple myeloma and its classic presentation with the CRAB criteria, we're discussing IgG related multiple myeloma and variants like IgM, IgA, and IgD can be a little bit different. So I really, really appreciate that lesson. And it makes so much sense that IgM multiple myeloma can cause cryoglobulinemia because the crux of cryoglobulinemia often hinges on the presence of IgM in those cryocomplexes. So just such a cool way to like even learn more about a different costume that multiple myeloma can share. I'll pass the mic to Muhammad to share what he learned in this case. But would love for you, Harry, to share. How is it to discuss? How is it compared to what you thought it was going to be? How are you feeling now?
Yeah, I was nervous coming in. I was nervous throughout. First time doing it, but it was a lot of fun. I think for me personally, it helped solidify a lot of things. And I've listened to a lot of morning reports and VMRs, but it's not the same, experience, of course, and kind of going through the thought process as much as possible when I observe. But I think when I discuss it, it feels a little bit different. I think it solidifies a lot of these things. But it's always fun to learn. And Mohammed had a great case and presented the case beautifully. And it was just such a joy to learn from him and learn from you. And learn from everyone in the chat as I'm looking at all these things. I'm like, oh, so many great ideas that I wish I had thought about in retrospect. But it was a lot of fun, and I appreciate being here and everyone else's support.
Yeah, you were absolutely superb. Our conversation was two colleagues talking to each other. I mean, you were really like I had to ramp it up in Alquat number two when I realized that you were really discussing at an attending level. So it was nice to be able to continue that conversation with you the whole time. Really, really nice job. Mohammed, what was it like for you to stumble into IgM multiple myeloma, and what did you learn?
Yeah, it was an interesting case because like when we first saw the rash, we thought of vasculitis, and we ordered the cryo and serum protein freeze and the autoimmune markers right away. However, the serum protein freeze was misleading, and now we learned why why it's not very sensitive test for the myeloma. You need serum immune fixation and sometimes urine protein electrophoresis, which was unfortunately not available at our institution. But however, we like when we have a hypocomplementemic glomerulonephritis, sometimes the schema or the mnemonic helps us like put help us think about the differential quickly. And if you open the hypocompatibility glomerulonephritis, you see multiple myeloma as one of the very important causes of hypocompatibility glomerulonephritis. Uh, Old age plus renal affection plus anemia, especially newly diagnosed, should always think about myeloma. That's what I learned during my residency uh, and in life. Myeloma is very, very heterogeneous disease, and like we see many different presentations, including just fatigue and some creatinine rise. Like saw some patient was 70 years old with creatinine 4. It does not have to have hypercalcemia, does not have to have bone lytic lesions, just creatinine rise and some hemoglobin, and some anemia and myeloma.
I love that takeaway. Older patient with glomerular injury, like glomerulonephritis, modify your illness script for multiple myeloma and be flexible about it, the possibility of this chameleon showing up in a way that you're not used to. I think that's a very powerful takeaway. Thank you so much. I'm sure you'll diagnose all of these cases much earlier than me when you're an outstanding nephrologist. That was awesome. Thank you so much, Mohammed. A really special day. I really learned a lot from this case. Alrighty, Shreyas, the mic to you, my friend.
Sure. Thank you, Mohammed, for such a wonderful case. I have a lot of teaching points from today's case. It was so packed with a lot of information. So hopefully I can finish in about 5 or 6 minutes. So we got a patient who presented with a generalized skin rash, and Harry taught us that whenever someone comes in with a generalized skin rash, we need to prioritize understanding what the patient looks like, the clinical setting, and also if the patient also has other systemic symptoms. And in our case, the patient had bilateral lower extremity edema. And also a general approach to a generalized rash, as Dr. Rabih taught us, could be to understand 4 dimensions, which are how extensive the rash is, how deep the rash is, and how the rash evolves over time, and also whether or not the rash is associated with systemic symptoms. And a wonderful point which Dr. Rabih mentioned, which I loved, was we always need to see if there is an objective correlate of the physical of some of the complaints which the patients are giving us, because it's not always necessary that the patient's chief complaint is always our chief concern. So we need to prioritize acuity and prioritize management if that's what's required at the very start. And the patient we had also had hypertension. And so hypertension along with edema helped us narrow down the problem to the kidney. And when we looked at the rash, we saw a diffuse violaceous rash, and that helped us think about what could cause such a diffuse rash. So we learned that it could be because of either a blood vessel problem or because of a platelet problem. And the palpable, non-blanchable nature of the rash helped us prioritize a vessel issue like vasculitis. And the patient also complained of dyspnea along with the presentation of hypertension, lower extremity edema. And so we also thought that we must not anchor just on the kidney, but pulmonary edema in this context can also mean, it could also mean there's a pathology either in the heart, the kidneys, or even the neurological system, because it could also be because of aspiration, because of a neurological disease. And so when we were tied everything together, and dyspnea in the context of our patient, with which included a vasculitic rash along with hypertension, bilateral lower extremity edema, we realized that dyspnea could either be because of either water buildup in the lung, which could be cardiogenic, although less likely in this case, or nephrogenic, or it could be because of maybe a cardiorenal syndrome. The patient could be bleeding into the lungs. And we also learned, Dr. Rabi taught us that anti-GBM disease generally will not cause a vasculitic rash because the basement membrane is very unique to the kidney and the lungs, specifically with regards to anti-GBM disease. And we had a quick thought exercise about what could just cause hepaturia. Dr. Harry taught us that trauma to the GU tract, any underlying urological pathology, be it any renal mass, ureter issue, bladder issue, and sometimes even menstruation, should make us think of only hematuria without any other systemic fingerprints or without any other systemic signs and symptoms. And hematuria along with AKI, there are generally three things we need to think about, which could be either glomerular nephritis, it could be either obstruction, which was probably a bladder obstruction, and also interstitial nephritis. And something we learned was that only 1/3 of patients with diffuse alveolar hemorrhage actually present with coughing up of blood. A vast majority of them develop anemia over the course of time due to slow bleeding and subsequent iron deficiency. And as the case progressed, we got some labs and we realized this patient is ANA negative, but he does have low complement. So we realized that ANA negative and normal complement in a glomerular nephritis has to be autoimmune, which could either be from ANCA vasculitis, IgA, or GBM disease. Um, and the fact that this patient had glomerular nephritis and purpura all over the body helped us prioritize the differentials, three important differentials of ANCA vasculitis, IgA, endocarditis, and cryoglobulinemia. And we learned that rheumatoid factor can actually be a very good proxy when we're trying to estimate whether or not this patient actually has cryoglobulinemia. And also hepatitis C testing is also useful, but then there are many causes of cryoglobulinemia apart from hepatitis C. And so some of the causes of hepatitis C negative cryoglobulinemia include a vast array of infections like hepatitis B, HIV, mycoplasma, autoimmune diseases like Sjogren's disease. And we learned that when patients with Sjogren's disease present with cryoglobulinemic vasculitis, that increases their chances of lymphoma by close to 30-fold. And the last important cause of hepatitis C negative cryoglobulinemia is a blood malignancy, which could either be lymphoma or myeloma, as myeloma was the ultimate diagnosis in our patient. And lastly, Dr. Rabi also taught us that this case is very atypical in the fact that one IgM myeloma is actually rare, and also multiple myeloma generally does not present with splenomegaly, but the patient we had presented with splenomegaly. So those are the teaching points I have.
I don't think anybody has been able to keep the whole audience here for 6 minutes after. There literally nobody left while you were doing teaching points, which is unheard of. There's usually a mass exodus at our mark. So really, really amazing job, Shreyas. That was superb. All right, y'all. I hope you had a really wonderful time. A big shout out to Ethan for scribing a really complicated case. And we really hope to see you all tomorrow for RLR. Bye.